Thanks for listening to the Pharmacy Podcast Network.
Welcome to the PBM Reform Podcast, where we dive deep into the world of pharmaceutical benefit management, cutting through the noise to uncover the truth. Since 2019, we've been your go-to source for the latest on how PBMs impact patient care, drug pricing, and the very future of pharmacy. Here, we champion the role of pharmacists, the most knowledgeable advocates for medication safety and expertise. Join us as we expose and generate discussions that are reshaping healthcare and explore how we build a better payment system which focuses on advancing pharmacy care.
Welcome back to the PBM Reform Podcast. You know, I wondered in developing this segment in 2019, and it started off as a short-term series. I had no idea that it would just continue. And there were several episodes that we developed with outsiders from pharmacy that were extremely knowledgeable of what was going on in healthcare around PBMs. And then the mixture of that intelligence with other data sources like Drug Channels. Drug Channels was one of the first organizations that I was following way back in 2011, 2012. And a shout out to Dr. Fine and his team, which just does amazing work. And then we started dialing into some more specifics, and things were changing. And people like Dr. Marian Mass, who's the co-founder of Practicing Physicians of America, and she is just a powder keg of knowledge and of energy, battling the early stages of PBM reform. And her partner, David Balat, is also part of this. And I'd like to introduce him today to the PBM Reform Podcast listeners. David, this is very special to have you here. Thank you for doing this.
Oh, that's kind of you to say. Thank you. And yeah, and then much appreciation to Marian as well. She's been an incredible partner in advocacy for all things PBM reform and many other things.
And if you want to follow David, he's active on X as are we. I still love absolutely using Twitter. I still call it more Twitter than X. At David Balat HC for healthcare. So David Balat at HC as in healthcare. And then also want to reference connecting with David on LinkedIn. He has an amazing following, very active on LinkedIn. But today we're going to be talking about a special report that you and Marian co-authored called Free to Care, RX for Reforming America's Predatory Healthcare System. I absolutely love the title. It's exactly what's going on. You and I were talking before recording. The irritation for me as a libertarian is when I see tax dollars making people extremely wealthy and then looking at people like my own aunt who cannot afford their medications based on a system that was purposely set up to make sure that those people had coverage. And now today we see that it isn't, because those state systems are finally revolting. Shout out to Arkansas for really starting the fire. I feel like that song, we didn't start the fire. I'm not allowed to use that, but that song comes to mind when I think of Arkansas and the Supreme Court that finally stepped in and really banged out some amazing outcomes. And now the FTC, we have the attention of the FTC, and I don't think that they're ever going to let go. I think the teeth are in, and they're going to shake this wild, rabid animal that is driven by profit and shake it until it dies. And let's invent something new, the next generation PBM. But let's do an overview for the listeners just regarding the intense and the amazing research that you've done over the years and how you've helped to form this report.
Well, Free to Care is an alliance of other advocacy groups. There are 34 made up of physicians, patient advocates, pharmacists, it it really takes up people from both sides of the aisle. One of our mantras is healthcare is personal, not partisan, and we believe that. And the members of this group, they do it because they believe in the mission. There's no cost to join. There's no obligation other than be involved. And of those groups, that represents close to 8 million people, 70,000 of which are physicians. And so when it's time to mobilize and we need to submit comments, or we need to have a day on the Hill where we're going to visit offices to talk about the specific issues in the report that we have on our website, people show up. And when people show up, and especially when they're the constituents of those members, the members listen. In fact, I also like to say this, that when we go to the Hill, it's a very different kind of experience, because typically we will have a number of constituents. If we're going to see, let's just say, 8 to 10 members in a given day, we will reach out to constituents from each of their districts to call them the day before to let them know, you're going to be having a meeting with this group, and we care deeply about what they're having to say. We'd like you to listen. So it's not uncommon for not only the legislative director to be there, but the member themselves, because they've heard from their constituents.
Visuals are telling, and it really helps. There's an intensity, obviously, around the continuation of people's opinions, and that those opinions are great. But when you start bringing the data in, and then you take that data and you make visualizations for our Congress and our Senate to understand what's going on, it's eye-opening. And that's why I really enjoyed what you developed in this visual, where it's toxifying America's medicine chest, and how PBMs and vertical integration is not in the best interest of public health whatsoever, because it sucks out the supportive revenue that's supposed to once again be taking care of people and their medication needs, and it just squeezes it completely, to the point, David, that the big organizations like CVS Health, for example, the yin and yang of good and bad, really, because the good is their pharmacists are just amazing people, and then the bad is this business PBM side run amok. But that is a perfect example of how integration through Aetna and looking down and looking at the visual. If you're looking at our YouTube channel right now, you'll see this a beautiful document in visual that shows that vertical integration. It's not in the best interest. It sounds good to the politicians based on the lobbyist that's presenting it. It sounds like it should save money, but it doesn't. It absolutely doesn't.
Oh, but it does for them.
Yeah.
Not for the consumers. And they never really go beyond the point of saying, well, it'll save money. They just never talk about who it saves money. But I want to give credit to the visual or the graphic that you're showing to our friend Adam Fine at Drug Channels Institute. Yep. He contributed that to our report, and he's been a friend for a good long time, and he's somebody worth following as well.
He is. We used to meet up in Vegas. We got sushi together several times. It's just brilliant. He reminds me of a Jedi Master of data analytics. So definitely. And I remember at a time where he was disliked by a lot of independent community pharmacies. And what's funny is now he's a champion per se, and it's not because of his changing views. It's just because the data has become so refined and so focused. Everything that he was doing years ago is now lining up, and it's like people realized, wow, he saw through the smoke, he saw the data in ways that many people didn't. And
yeah.
Of course,
well, the man has coined a term that has told a story again and again, and has been so impactful on the Hill, which is the gross to net bubble. And nowadays, when you say those words, there's a picture that appears in your mind, and what that is the gross to net bubble is what is the price of the drug and what is the net price of the drug. So what is the overall price, and then what is paid to pharma. And if you look at that graph, that net price to pharma, it's relatively flat over the last 20 years, whereas it's near exponential on the overall price. So the difference between those two lines, which diverges, that's the bubble. And that bubble continues to get bigger and bigger and bigger. Who's taking advantage and who's benefiting from the dollars that bubble represents? And we know from a lot of different sources now that it is the PBM and the insurance company, and in some cases the employer, and in some cases government entities, but by and large it's going to be the insurance companies and the PBMs.
The system has eaten its own. There are 8,000 less pharmacies in the United States than there were 28 months ago. And the majority of them are chain community pharmacies that are now out of business, because once again, the system didn't sustain itself with with the way it was designed and the confusion it was designed in. And that's telling in and of itself that you've ravaged your own company in the existence of communities that are desperate for pharmacy services.
Well, their singular goal is that of shareholder wealth. And they've taken the playbook from both the insurance company, the PBMs have. They've taken that playbook of doing that to pharmacists from both the insurance company and especially the hospitals that have taken control of these independent physician offices and employed them. And using the same language, well, it'll save money, there'll be efficiencies, economies of scale will be evident, maybe for the hospital, but for no one else. And it's been proven again and again through various research studies that the cost of care increases and the quality is not really improved. And in some cases, it's been demonstrated that there's degradation.
All right. So is this something, and when I think of CMS and how it's dictating and driving down how things get paid for, who's getting paid, we haven't even reached we haven't reached provider status at a national level. We're only seeing provider status for pharmacists at state levels. But when you start mixing in the cookie batter of this new age of getting pharmacies paid, pharmacists paid, the element of driving it by the prescription is something that needs to go away with the run amok models of the current three big PBMs now. And the reason is because I just interviewed, which will be coming out on Twerks This Week in Pharmacy, with Dr. Joey Mattingly, who was testifying to his own state systems as reference to PBMs. And his statement was that if a pharmacist dispenses a medication, they're paid for their services. It's embedded. Sometimes it's negative. Sometimes it's minimal. Sometimes it's not, covering costs. Then there's a scenario where the pharmacist looks at the patient's medication list and they say, for this specific prescription, based on your current usage of medication, I'm going to say no to this prescription and I'll reach out to your physician to get something else in place, but this is going to be good for you. So we just said that a qualified doctor of pharmacy got $0 for their services because they didn't dispense the medication, even though they kept that person safe. And so the model of how we pay for prescriptions today, everything attached to the prescription as a dispensing fee needs to go right out the window. You should be paying a pharmacist in a pharmacy for their services, regardless if they're dispensing or regardless if they're not dispensing, because it's much bigger than dispensing.
Well, it's out the window for everybody but their own pharmacies.
True.
They value themselves. They just don't value anybody else. So I agree with you. And it's, if you want to understand motivations, you need to follow the dollar. What is it that they're motivated to do? They're motivated to enlarge their market share by pushing out the competition and gaining more business and revenue for themselves so that they can make Wall Street happy and have a bigger share price for their shareholders, and they can keep their job and get bonuses. That's how corporate America works.
Unfortunately. Yep. And in some spaces, I can see where it works, but the lumber companies that are out there, the small lumber distributors, aren't getting an audit 6 months later for all the wood that they sold and shipped out, like a pharmacy is in the name of an audit. And the audit does nothing, as you said, does nothing for anybody except for the PBM that wants to get the money back in some form. And of course, it leaves our pharmacies with in many cases nothing left to service. And now we're seeing it with the pharmacy deserts, and it's unfortunately, David, it's going to get worse before it gets better because of the domino effect. But what is the light at the end of the tunnel is the fact that it finally is getting a massive amount of knowledge and exposure and intelligence that the lobbying groups like PCMA, they can't spin it anymore. People are realizing the data is data. It's black and white, and they're seeing what is actually happening with the dollars. They're following the dollars. They're following the rebates. Googling PBM reform, it used to be we might have one or two stories. You cannot get away from relative topics within minutes of being published, within days of being published, about the news that's coming out about it. So, I mean, that's the good in all of this.
And what's important about those stories, and I started seeing a trend among some of the words as you were scrolling. What has taken this over the edge, which has been so difficult, has been getting the employer involved, because it's been very easy for people to say, well, you people in the healthcare world, you're just jealous that they're getting a bigger piece of the pie, or it's professional jealousy, or they're taking business from you, whatever the case may be. They always make it a financial reason. And PCMA has always said, well, I mean, why do employers hire us unless we're providing them a benefit or a service? But now that they're getting involved and their voices are being heard, you can't argue with that. And so it's important that they've done that, and it's even more important that they continue to do that. More polls that are coming out and showing their dissatisfaction with the level of transparency, it means something. And so that's why we're hearing news about, I think Wendell Potter just put something out, and I don't necessarily agree with him on a lot of things, but on some things he does a good job, as far as I'm concerned, in my opinion. But there was one where he was talking about CVS looking to break up. That would be positive, but I think we need to look at that with a wary eye, because how they end up will be very, very important. Ultimately, if we're talking about PBMs, the root cause of it all is the safe harbor from the anti-kickback statute. It was 1987 for the GPOs, 2003 for the PBMs. No member in Congress will touch it. That safe harbor from the anti-kickback statute effectively gave the PBMs and insurers, by way of purchase and acquisition of those organizations, the ability to have the same kind of business plan as the Mafia. Call them rebates if you want, but they're kickbacks. They're just sanctioned by the government. No other business gets to have kickbacks be the crown jewel of their business model, except for GPOs and PBMs. And now we're seeing the PBMs, because of the legislation that is specific to the PBMs, they're looking to find shelter under the GPO umbrella, because they have the same exemption or safe harbor from the anti-kickback statute. So yeah, it's good to see that other people are using that terminology, because there are so many similarities.
Yeah, the Mafia of what it is, it's this insiders club that is, once again, like you said, it's the stockholder, it's the profit, and it has really nothing to do with healthcare. And we've definitely lost our way. I do want you to give a shout out to the listeners, the pharmacists that are independently owned, the pharmacies that are independently owned. As we're moving forward, we see cracks in the armor. We see that there's going to be changes. Of course, many of our pharmacies are going out of business just because they can't lights on. What do you say to the pharmacy owners that are out there now in doubling down in the efforts to get Congress people into their store to listen to their stories and meet with them? Like, what are some of the other things that you could you could do if you were a pharmacy owner?
Well, absolutely do that. Do what you're doing. Join these groups. Be a part of the effort. Make your voice heard. I would say not only get to know who your lawmakers are, make sure they get to know who you are, because you're the expert. You're the person on the ground. May I tell just a quick story that will be illustrative? When I first started working for a think tank, I went to DC. It was one of my first trips there. I was excited about talking about the subject that I love, which is healthcare, to these healthcare legislative directors for various congressmen and senators. I was advising a number of them before I worked for this place anyway. So it was good to go into the office, and I wanted to really get into the meat of some of the issues that I found important. What I learned is that there's a lot of breadth, but not a lot of depth. And one of the directors was excited to work with me. She said, "Let me show you something. I've got a diagram of the healthcare industry." And she shows me this piece of paper hanging on her desk. And you can break it down to a triangle. And it was pharma, insurance, hospitals. You can laugh, but that is the viewpoint of many of the people in DC. Why? Because that's who shows up. Pharma lobbyist, hospital lobbyist, insurance company lobbyists. That's who shows up. So when they think healthcare, they think those groups, because that's who they talk to. And that's who's informing them and educating them and training them as to what's going on. It's that old adage, if you hear a lie long enough, it becomes the truth.
Yeah.
That's exactly what's happening. So I tell that story to encourage you to tell the truth as often as possible. I would also add this. Y'all are scientists, very science-based. Data is great, but data only touches this. What leaves an impact is how you affect someone emotionally. Mm-hmm. And that's the stories that you can tell. So if you're not great at remembering them, write them down. Tell your stories. Talk about what you've done. Talk about patients not being able to pay their bills or buy their medication. Whatever the case may be, you've got tons of them. Employ them, use them. You've got a great arsenal. Use it in this war, because that's what this is.
I agree. There's lots of people in the community who are frustrated, who are extroverts that would love to use social media. Even something that's happening that you could film right at your own community pharmacy, and the pharmacy owners would love that. So that's a great idea, that even though they're engaging the state Congress or state Senate, also engage your clients and your customers and your patients to tell their stories. Loretta Bosling just tweeted something this morning about one of her friends that cannot get her medication for her child paid for, and they've gone through all these hoops. And I've even sent reference to Accessia Health, which is a company that will help you get revenue, very creative ways in getting your medications paid for. But that's not the ultimate solution. It's like a Band-Aid to the system that is bleeding. And it's once again, it's because of as you said, it's the insurance systems that have way too many things in place that only work to their advantage and not to the advantage of everyone that's in healthcare. And we see it. But that's all. Even the jovial social media, Dr. Glaucoma Flecken, who's
yeah, I'm familiar.
And he tells that story. He finally does it in a humorous. And isn't that funny? That it goes back to our emotion, because not only emotion from anger and emotion from being sad and seeing what's happened, but the emotion in laughing. And I laugh at him because what he's saying is absolutely right, but he does it in such a sarcastic and jovial way that it makes sense.
Yeah, the satire is real.
It is real. It's unfortunate that it is so real. Have you gone to pharmacy conferences to actually meet with pharmacy owners at one place at one big event or anything like that?
I don't know that I've been to. I've worked with the lobby group in Texas as we were working on PBM reform, but I can't say that I've been to any conferences, although I'd love to attend.
The NCPA, the National Community Pharmacists Association, that's the Super Bowl of independent community pharmacy. That's happening on October 26th of this year, 2024. And if you have the ability to go to Columbus, it's a wonderful gathering. I know Antonio Chacha and many of the writers that are the powerhouses. Like I said, the Jedi Knights of the Round Table. So it's like we need more of those, and we need more people like you, David, that are intelligent fighters that can fight fire with fire and data with showing it.
I appreciate that. I'd love to go, but might have to wait till next year with short notice like that. But you're in good hands with Antonio. He and I share not only a love of beating the crap out of people when it comes to policy, but we also share a love of professional wrestling. So we always have good conversations surrounding those two issues.
Yeah, that's a good analogy right there. So that's
it's a lot like it. There are a lot of similarities.
Yeah, very much. Well, I've enjoyed this time with you. I hope you promise us to come back and maybe we can build a panel and get Marion back too, because I miss having her on.
Oh, I would love to do this with Marion. I can't guarantee that we'll talk about much, but we're going to cut up a lot.
I appreciate it. What's the best place I'm going to give out the website again, just to let everybody know, freetocare.org. Once again, that's free, the number 2, care.org. I'm going to have that in the show notes. I'm also going to have David's LinkedIn profile. Thank you so much for sharing your insights with our pharmacists and our pharmacy professional listeners that are out there fighting and doing so much for their communities one by one and what's happening. And like I said, I think we have a lot of work to do, but at least we have a blueprint of how to get there. And you've been part of that blueprint. So thank you for that.
I would like to just leave it with one thing. I also want to say thank you to the independent pharmacists. And I want to really make clear, I don't know if anybody has seen my coffee mug that says coverage it's not equal to care. And I believe that. In fact, this was made by an intern because they hear me say it so often. We can talk about coverage. We can talk about how important Medicare is and all these insurance approaches and strategies are. But ultimately, what healthcare is about is the relationship between medical professional and patient. What pharmacists do is important. Mm-hmm. Can't replace you. They just want to cubicleize you, is a word that I've actually heard folks use. They want to treat you like an engineer and just tell you what the hell to do and have you shut up and fill the script. Right. That's not how it works. Don't let them. Things are hard, and they may get harder, they may not. We don't know. But I can sure tell you that unless we do something, it will get harder. You've got to act. You've got to go out and assert the fact that you are the caretaker, you are the professional, you are the trained individual that takes care of patients. That's what's most important. And that's something worth fighting for. Absolutely.
David, this has been wonderful. Thank you so much for sharing your knowledge with our listeners and the work that you do. It's very meaningful and we appreciate it.
It's my pleasure.
Thank you. You're listening to PBM Reform Podcast. Make sure you subscribe on all platforms, hot on Apple, Spotify, even on Amazon, and share this show with a politician, with one of these people that you're trying to get, and post this on your Facebook as well, and let the public know. Let the public know what's going on and get them to be a part of it. And we thank you for listening to the Pharmacy Podcast Network.